Okay, some definitions. An analgesic. Analgesia refers to the reduction in sense of pain. However, the loss of consciousness is not there. So if I wanted to have, if I had a sore foot because I twisted my ankle, I could take an analgesic. It doesn't make me unconscious. I just don't, I have the pain sensation is deadened. Sedation, on the other hand, as the name implies, has a soothing, calming, or tranquilizing effect. And often antidepressants can be used as a sedative. So if somebody is anxious, maybe because they're a little bit in pain, in addition to an analgesic, I could give them a sedative. Having a quiz, yeah, there you go. Hypnotics are drugs which induce sleep, often not necessarily with the loss of consciousness. So there's medications that we can give where the patient does not have recollection of what's going on. They're basically hypnotized, but you can still talk to them. Kind of fascinating agents. And what's that? Scary, yeah, well. Anesthetic agents are ones that basically have either locally or general over the body, they have a reduction in pain and also have a loss of consciousness, or with or without a loss of consciousness. So you can do I'll come back to that. Paralysis then is the loss of ability to move body parts, as the name implies. So our analgesics are two broad classes, narcotic and non-narcotic. And the term narcosis refers to a state characterized by stupor or insensibility. Basically, you're just out of it. Pleasant dreamlike state without the loss of sensations. So we'll give, again, analgesics for patients who are in pain. This is just showing the perception of it. The pain stimulus causes an impulse to be sent back to the brain. The brain then sends something back as far as movement of the muscle or whatever. Our narcotic analgesics, one of the major classes are the opiates, and these are the ones that are derived from poppy seeds. You know, that scene in The Wizard of Oz where they're going, poppies, they're all stoned, they don't care. But morphine is the primary drug, as is heroin, that is derived from the poppy seed. When I was working for a company by the name of Mallinckrodt, who, if you look at the endotracheal tubes, they're manufactured by Mallinckrodt. But they were one of the largest importers of morphine because they had a pharmaceutical arm to the company, and they would import poppies to make morphine, hopefully not heroin. But also, along in that group are codeine, and then your drugs like oxycodone and hydromorphone, or Dilaudid. Very potent opiates. They all have as kind of a side effect respiratory depression in higher doses, so you need to be careful in administering them. The two synthetic opioids that are present, so they're man-made, are meperidine or Demerol and fentanyl or sublimase. But they're very potent pain relievers in that case. They're reversed through a drug called Narcan or naloxone, as we've talked about before. So if you get an overdose of codeine, you can really reverse it with Narcan. Your non-narcotic analgesics come in a bunch of different flavors. They all induce analgesia at some point. Sometimes they have an antipyretic, meaning anti-fever functions with them, and sometimes they're anti-inflammatories also. So that instance where I twisted my ankle, a combination analgesic, and an anti-inflammatory would be appropriate. So something on the order of, say, ibuprofen, which is an anti-inflammatory, non-steroidal anti-inflammatory. Acetylsalicylic acid, ASA, also known as aspirin. You'll see that. So if you ever see a term like a salicylate overdose, what they're talking about is an overdose of aspirin. And acetaminophen, obviously, is one also. Those drugs, even though they're non-narcotic, they can lead to the need for mechanical ventilation. And all of them really have problems associated with other systemic body systems. Aspirin, as you know, in high doses can end up leading to bleeding dyscrasias. Acetaminophen can lead to liver failure. Ibuprofen has, I want to say it's liver also, as a matter of fact, liver or kidney in high doses. Sedatives are used to treat psychotic episodes, or can be used to use psychotic. We typically use it more for the anxiety end of the spectrum, but there is a condition called ICU psychosis, where literally they have and do you know what the difference between psychoses and neuroses are? A neurotic tendency is just one of those weird behavior things that we have. OCD is a neurotic problem, okay? Psychotic means you have a break with reality. You're not there anymore. I don't know if I told you guys the story, but stop me if I have. But I had a patient who was in for Guillain-Barré, and he was on the ventilator for like 3.5 months. It was just painful, and he was in the ICU for probably 2.5 of that period of time. And finally, he got to the point where he had a trach in, and we had a fenestrated tube in, and we were going to deflate the cuff and have him talk for the first time. And I was really a shit, because we ended up calling his wife on the phone, and he was talking to her on the phone. It's the first time she had heard him talk in 3.5 months, and she's crying, and he's crying, and I'm crying. It was a mess. But he's telling me a story about how when he was in the ICU, he's laying there, and he looked over at the wall by the side of his bed, and there were these boxes sitting there. In the boxes were arms and legs. Whoa, that's a psychotic episode. But it also, I'm just thinking of all what Freud would say about all the subliminal hints there, as far as he's paralyzed, and there's his arms and legs laying in a box next to him. So that's an ICU psychosis, and it quite often does happen because of lack of sleep. If you think of somebody who's in the ICU, you think, oh, they're sleeping peacefully. Nonsense. We're flipping on the lights. We're in and out of the room. There's no privacy. Although we've gotten better at it over time, patients do get a bit screwy. So there. Two of the typical antipsychotics. The one I would like you to know is Haldol. And by the way, let me just go back here and point out ones that I think you should have an idea on. Morphine, you should be able to identify as a narcotic. Codeine, Dilaudid. And as far as the opioid, fentanyl. That's quite often used. It's a very wonderful drug for pain, but potent, to say the least. You should know naloxone, obviously. Those three, if you don't know, I'm sorry. We'll have to have a long discussion, but acetylsalicylic, aspirin, ibuprofen, and acetaminophen should be one of them should be in your medicine cabinet. I'm not sure which one. Or all of them, yeah. Haloperidol or Haldol is a drug that's often used for those psychotic breaks that you end up seeing. Some problems with it, but it is a very good drug for that purpose. The anxiety that patients have, it's not only that they're in pain, but they're just anxious. They can't talk. They got this tube in their throat. Maybe they woke up. Last thing they remember, they're driving down the street. They got hit by a car, or they got in an accident, and now they're in the ICU, and they wake up, and they're like, where the hell am I? Well, that anxiety, that apprehension is understood as far as that's concerned. The benzodiazepines, the most common one, the one I want you to know is Valium. It's the most common benzo that we have, although there are some other ones that cross over that I'll talk about in a few minutes. But Valium's a wonderful drug for that purpose. Sedatives are also used for depression. I'm not going to go into that, but they are used for that purpose. And there are some antidepressants that exist some MAO inhibitors, some tricyclic antidepressants. The only one that I want you to be aware of is the last one there, Xanax. I think we took a survey one year, and that was the one that most of the class was prescribed for whatever reason. But at any rate, hypnotics. Hypnotics are good when you want to basically have somebody induce sleep. They're used as a pre-anesthetic agent quite often to calm the person or induce some sleep to be able to then administer the general anesthesia. The one I want you to know is midazolam or Versed. It's a very wonderful drug, and this is, like, as I said, it's a hypnotic. So when they're doing a procedure like a colonoscopy, they'll give you Versed. You have no clue what is going on, but they can still communicate with you. Are you having any pain?
What's the other one they give you too?
Propofol. We'll talk about that one in a second. That's coming up also. That's under, well, let me back up. These are some other hypnotics that are there. They're barbiturates. I don't really want you to know any of these necessarily, but these are also used quite often for anti-seizure situations. Your barbiturate hypnotics. So pentobarbital, pentothal, those are all there. Leave it at that. Anesthesia, we can kind of subdivide into either local anesthesia, say giving some lidocaine for an arterial puncture would be an example of that, just a local blockade, or a regional blockade that they could do where it's a group of nerves that are being blocked as far as their sensory impulse. And again, there's no loss of consciousness there. These are just something where you can do. So a spinal anesthesia or an epidural anesthesia for childbirth. A lot of times there's nerve blocks that are given for patients with chronic pain to try and control it. And then there's general anesthesia, and this is what we typically think of when we go for a situation where somebody's going for surgery. They're going to be under general anesthesia in many cases. And they're basically, they have no perception of what's going on, they have no reaction to pain, and they are unconscious as far as that is concerned. Two different ways. Go ahead, Willie, I'm sorry.
Yeah, just for the pharmacology test that we're going to have at the clinicals, is that going to include these medications also?
No. Lidocaine would probably be the only one that you should be aware of. Yeah, no, these are just when you finally get into the ICU, you're going to see a lot of ways that we control patients because mechanical ventilation is not a natural thing.
While we're on that subject,
Sure.
the sheet that you gave us,
Yeah.
I think it was
Yep.
the end of last semester.
Yep.
Those are pretty much the drugs that we would be prescribing.
The drug test that I created for the clinical sites, and some of them use it, some of them don't, was based upon that. I can administer general anesthesia through two different fashions. An inhalational route, which is the way that the anesthesia was first created back when ether was utilized. Have a patient breathe in the vapors, and because the partial pressure of that gas then increases, it gets in the bloodstream, and you basically have an anesthetic reaction. You can also do it through an intravenous route, and that's another mechanism to do it. I don't think you really need to know the different anesthetic stages. Notice Arthur Goodell is there, the Goodell Airway fame. But basically, the stage 1 is just amnesia or light analgesia. Stage 2 is actually called excitement, and this is where we will use those inducing agents to go ahead and knock the person out so that we can go to the deeper anesthesia, which is stage 3, and that's typically where we want to end up being. There's 4 phases with 4 planes within stage 3, gradually getting deeper and deeper and deeper. Stage 4 is the one we want to stay away from, however, because that's medullary paralysis. You paralyze the medulla, you lose blood pressure, you lose heart function, breathing function, everything. So what the trick is is to stay in stage 3 without getting to stage 4. And that's where the anesthesiologists and the CRNA's role is to go ahead and evaluate the patient to stay there.
Give us an example of a type of drug for each stage.
No, you don't need to know them. Stage 2 inducing agents would be something like Versed, quite often is used. Propofol is used. So here's basically the 4 stages which you end up seeing as far as how they react. And you don't need, I'm not going to ask you anything about this, but just need to have an idea. Of the 3rd stage is where we have the operative, where we do the surgery itself. And never want to get down to that stage 4. A lot of inhaled anesthetics are present. The one that we're probably most familiar with is nitrous oxide. Notice that says nitrous oxide, not nitric oxide. Different drug entirely. And laughing gas, which you would get at the dentist. Makes you feel very happy, and you could care less what happens to you at that stage. But the other ones that are there are more commonly used as inhaled anesthetics in the OR, and a lot of it is just preferential on the part of the anesthesiologist or anesthetist as far as what they want to end up doing. Intravenous anesthetics are also used sometimes in conjunction with inhaled anesthetics. Inhaled anesthetics are easy. If you don't want the anesthesia anymore, you take the mask away. Poof. The effect is gone. IV anesthetics, a little bit harder because it's already in your system and you got to wait for it to be metabolized off. Usually the intravenous anesthetics will be used as induction agents to get you into stage 2. And again, we talked about midazolam, and this is also where Diprovan or propofol is used, although propofol also has a hypnotic, as does Versed, effect in the same process, depending upon dosages related. My wife had gone in for a colonoscopy, and they kept referring to the medication that she was on as Diprovan. Oh, I said, oh, you mean propofol? They go, well, you can't say that. Because Michael Jackson died of propofol, so nobody wants to know about that. If you ever see propofol or Diprovan, it's a white liquid, and it's also been dubbed the name Milk of Amnesia, which I think is a kind of cute name.
It's the best sleep ever.
Oh my God. It's a great drug. Yeah.
Do you want us to know any of these ones?
Diprovan, and I already told you Versed. So some of these drugs have multiple effects, and it's dose dependent, okay? But these are ones that are typically induction agents. This is out of Cairo, talking about the different levels of sedation. What I do want you to know is that a sedative can be used just simply to relax, or in the case of conscious sedation, I do want you to know that terminology. Conscious sedation is where you're able to respond to verbal commands, but your ventilation is maintained. And we will do conscious sedation for things like elective cardioversions. So somebody has an irregular heartbeat, we want to apply electrical energy to kind of shock the heart back into a normal rhythm. Seems like a brutal thing to do, and it is. You shoot 50 joules of energy through somebody's chest. You would think that that'd be a little bit, oh boy. But what we'll do is we'll use conscious sedation for them for that purpose. And then you go deep sedation and finally anesthesia. But conscious sedation is the one I want you to know.
And also with that, know that that's a procedure that can be done, or we don't have to know in depth like that?
You will come across that another day.
Okay.
Yeah. Yeah, data.
So for the conscious sedation,
Mhm.
so they can breathe on their own, but will they remember anything like after their?
Typically, we're going to use a drug like Versed. If you use something of Valium, they may have some recollection of it, but usually it's quite deeper than the normal sedative you would end up giving somebody. Because I mean, it's painful. I mean, yikes! Putting a bit of energy through somebody's body is kind of a cruel one. But you'll also see conscious sedation used when they want to go ahead and do some orthopedic procedures. So you get a little kid into the ER who they got to set his leg because he broke his leg. You want to get him so he's sedate so that you can manipulate him, but there's a fine line between being consciously sedated and being deeper sedated to the point where you actually knock out their ventilatory drive. So one of the things that the American Society for Anesthesiology has said is, if you're doing conscious sedation, don't just monitor with pulse oximetry, monitor with end-tidal CO2 also. Because end-tidal CO2 will tell you when your CO2 levels start to climb or apnea ensues. You won't be able to pick that up with a pulse oximeter. You ever put a pulse oximeter on yourself and hold your breath? And watch how long it takes to desaturate? 2-3 minutes.
Can't hold my breath that long.
Well, okay. Got a point there. I was actually at a trade show and a guy was held his breath for 4.5 minutes. I'm just going, holy, how can you do that?
He's trained.
Yeah, he was. He was a swimmer. The sedation and analgesia, what I would like you to know is that there is a mechanism by which we can tell how deep somebody is. It's called the Ramsey scale. Other than that, I'm not going to expect you to know the different levels. It's 1 through 6, and 1 is awake and no problem. 6 is, well, they're not sedated, let's put it that way. And 6 is asleep, pretty deep sleep. But we'll use this as a mechanism to gauge how deep of analgesia and sedation they're in. So do I need to dose them again, or can I wait another half hour to be able to dose them? Okay. Talking about muscle contraction. We know that it does this because of action potential that's created and the acetylcholine that is present in the synaptic connection between the nerve ending and the skeletal muscle. That parasympathetic connection, when acetylcholine comes across, it stimulates the muscle to contract. That's basically how muscle contraction happens. It is then broken down by acetylcholinesterase, and the process is started over again. Okay, so that's basically the essence of muscle contraction. Okay, pardon me? Yeah, that's basically what we talked about prior. Now we're going to talk about how do I prevent that muscle contraction from ever happening. And there's 2 mechanisms that we utilize. One that causes a massive depolarization that doesn't repolarize, and one that prevents the depolarization from ever happening. Our primary indications, and you should know these, are to facilitate endotracheal intubation, especially in a patient who's combative. They'll do it if they're in surgery and they want to prevent that patient from moving. You know, I'm doing some surgery on their leg. I don't want some inadvertent movement of the leg. I'll just paralyze them. And we'll use it in the ICU to facilitate mechanical ventilation. So somebody who's fighting the ventilator, somebody who's dysynchronous to the ventilator, can actually cause more harm to themselves, and we need to ventilate them. So we'll use a neuromuscular blocking agent to accomplish that. These agents result in paralysis. That's all they do. They do nothing to consciousness. So one of the things that should always be done is a simultaneous use of an analgesic or deep sedative along with that paralytic. It's just cruel and unusual punishment to paralyze somebody, even if I'm ventilating for them and they know they can't move. That's just awful. So, night-night. There they go. The first group I want to talk about is the non-depolarizing agents, and basically these are competitive antagonists that binds to those acetylcholine receptor sites. So on the on the muscle, skeletal muscle, there's sites where the acetylcholine would bind to create the reaction with the muscle and to stimulate it. These agents block that, so if I don't have any acetylcholine binding, I can't have any muscle contraction. The problem with these, not the problem, but the downside to them is that they block all over. Sometimes in areas where you don't want them, so they can result in hypotensive episodes, because the smooth muscle isn't contracting to maintain blood pressure, and bronchospasm as a problem also. So that's some side effects that you end up seeing with these non-depolarizing neuromuscular blocking agents. And these are the ones that we would probably see.
Should we know all those?
Can you just remember that curium at the end of it?
Yeah.
There you go. The precursor was a drug by the name of curare, and the curare was the substance that they put on the end of darts with the blowguns to paralyze. They recognized it as a paralytic agent, and if the enemy was there and you wanted to get rid of him, you just got paralyzed for a few minutes. Boop, they're dead. You can, on the good hand, reverse these agents, and the drug that you see there, neostigmine, is one that you should see from myasthenia gravis treatment, but they're basically inhibiting the action of anticholinesterase, so the acetylcholine would stay around longer in the process and override the agent that is present. Pyridostigmine and neostigmine are two that are there.
You know those?
But you already know them, right?
Yeah.
There you go. The one that in fact, I think it's the only agent that is a depolarizing agent, is a drug that you'll need to know also, succinylcholine, also known as an anectine, also known as Sux. Give them some Sux. This is one that works in a different fashion. It causes a massive depolarization of the muscle, which then also has a prolonged refractory period. So where the non-depolarizing agents cause paralysis for a prolonged period of time, this agent basically causes a massive depolarization. There may be some twitching, but there's paralysis. And there's no way to reverse that paralysis. For the 5, 6 minutes, 8 minutes that they're paralyzed, we wait it out. Which means that if you're using Sux and you're at the head of the bed bagging that patient, you better damn well be aware of that the patient's going to be paralyzed, because they'll be dead by the time the drug wears off. Okay? So real quick onset, not a real long duration, but long enough for me to tube the guy. If you can't tube in 5 to 10 minutes, we got a definite problem, guys, right? Okay, so succinylcholine is the only depolarizing agent that you may have. You should be able to distinguish between those two group of drugs. And these are just basically, again, the onset and the duration. And you can see some of the different drugs. Pancuronium, formerly known as Pavilon, was one that I don't know to what extent which one they currently use so much as, because I'm a little bit out of that realm, but they still have neuromuscular blocking agents that are used.
They just give these systemically, and then it affects whatever it affects.
And that's part of the problem with the non-depolarizing agents. They affect throughout the body. So small enough dosages, you probably won't have big problems with loss of blood pressure from the hypotension, but you may end up needing more frequent dosing because the dose isn't high enough. So, but yeah, 3-4 hours, you want to just paralyze them so we can do procedure on them or whatever. Go ahead and do it. Just for mention, I'm not going to expect anything on it, but skeletal muscle relaxants are different than paralytic agents, and they're just basically used to treat things like back spasms, muscle spasms in other areas. Let it go at that. The general classification of diuretics, what I want you to know is that they're used to reduce blood volume. We've talked about this previously. You will see these in the ICU as you pass through. For right now, I'm not going to expect that you know the different drugs that are there, other than diuretics are used to reduce blood volume In the fall, we'll get into how each of these groups work, where they work. Loop diuretics, where do you think they work? Lupa Henley, perhaps. Osmotic diuretics are used, very, very potent diuretics. They're used to, usually in head traumas, to pull off the reduce swelling. But we'll come back and visit them again. And the downside to any diuretic is obviously that there's potential for electrolyte disturbances to happen. We know about our positive inotropes, dopamine and dopamine. Those two should not be unfamiliar to you. And then we know there's some other drugs that raise blood pressure. The primary one I want you to know, and you should know, is epinephrine. It's one of our primary drugs used in advanced life support. And I'm not even going to get into the antihypertensive agents. But there's different groupings that are there. I think we've talked about them before. We talked about from pharmacology time. The nitrates being the ones that are the most potent. Oh my God. All kind of antidysrhythmics that we'll encounter. And the last semester we'll spend a little more time talking about things like adenosine and things like amiodarone and propanolol and lidocaine and different groups. But for right now, you don't need to know them. All right. During advanced life support, if you have a situation where it's a code situation, the primary IV access is the antecubital vein. Good old friendly arm vein. You can run a lot of fluids through it. You can go ahead and run every drug through it. It's not a problem. Used to be our second line was down the endotracheal tube. So we intubate the patient, we go ahead and squirt the epinephrine down the endotracheal tube, and because the lung is such a vascular organ, it eventually gets into the circulation. Now that's changed so that the antecubital is primary, secondary is intraosseous. We're using either a drill or a gun or a manual penetrate into the medial aspect of the tibia or the posterior end of the humerus or the sternum. It is just the weirdest. But it's very quick access that you can get into the area, and you can run in blood, fluids, whatever. Runs directly into the marrow, directly then into the venous system, and it's back to the heart in the process. So for right now, we're not even going to pay attention to this slide. But I just wanted to bring up that it used to be a mechanism. We used to put drugs down the tube, and hopefully no one is using it. Yeah, Alien MV. That was the little mnemonic you could use. Yes. I knew you would.